is the last session of the annual PSSLD meeting. This is a very interesting session. There are a lot of diversified talks starting from hepatitis E and pregnancy-related issues. And for this session, I would first like to introduce the chairs of the session. Professor Ashfaq Ahmad. Professor Ashfaq is a former professor of gastroenterology at Hamdard University, and now currently he's working as a consultant gastroenterologist and hepatologist at National Medical Center. The next chair is Professor Nasir Lak, who's working in SIUT. Dr. Abdullah Khalid, who's an associate professor at Dow University of Health Sciences, Karachi, and Professor Abdul Qadir, who works as gastroenterologist and head of department at Muhammad Medical College, Mirpur Khas. Along with that, we also have Dr. Zishan Ali, who is associate professor of medicine at Jinnah Postgraduate Medical Institute. So thank you very much, all the chairs, for gracing this session. We begin with the first talk, and the first talk is by Professor Sudhamshu K.C. Professor Sudhamshu is a professor of hepatology, National Academy of Medical Sciences, Kathmandu, Nepal. He's also a coordinator of DM Hepatology Program, Nepal, and he's also a president of Nepalese Association for the Study of Liver Diseases. And Professor Sudhamshu is actually talking about hepatitis E and the extra liver manifestations, the menace beyond the liver. So over to you, sir.
Assalamu alaikum. I feel privileged to be presenting on hepatitis E, which is a common problem of this part of the world. My sincere thanks to organizing committee, especially Professor Zaigam Abbas and Dr. Amna Suban, for this wonderful opportunity. In next 15 minutes, I'll be talking about hepatitis E, the menace beyond the liver. First recognized in 1980, this disease is caused by a RNA hepatitis E virus. It is predominantly disease of a developing country, but it is also found in developed country. Every year, an estimated 30 million people suffer from this disease, and more than 3 million clinically significant cases occur, with around 70,000 deaths. The commonest route of transmission is fecal-oral route and is found in the country where fecal contamination of drinking water is there. While this disease is endemic in developing country, sporadic outbreaks has occurred in almost 63 countries worldwide. It has at least 4 mammalian genotypes, genotype 1 to 4. Genotype 1 and 2 are found in humans, while genotype 3 and 4 in animals. Recently, 5, 6, 7, and 8 has been described. The incubation period is 15 to 60 days, with a mean of 40 days. The clinical features are similar to other hepatotropic viral infection. There is a wide variety of presentation that ranges from asymptomatic anicteric hepatitis to fulminant hepatitis. It carries high mortality in pregnant women of third trimester. The variation may be due to various genotypes. In developing countries, genotype 1 and 2 causes illness in a younger age group, while in Western world, genotype 3 and 4 causes illness in the median age of 50 years. This is the map showing HEV genotype. You can see that predominantly genotype 1 is found in our part of the world, and in European country, there are genotype 3 and 4. Regarding HEV in Nepal, Kathmandu, which is capital city of Nepal, is a valley by geography, is highly endemic region for the HEV. 5 outbreaks has already occurred, first being in 1973 and last in 2007. The last outbreak in the country was in Biratnagar, eastern part of the country, in 2014. Sporadic cases occur in between epidemics, and it accounts for 15 to 50% of the acute viral hepatitis cases. Fecal contamination of drinking water due to poor sewerage system is the main culprit, and when the herd immunity is low, it seems to be causing outbreak. However, the low herd immunity may not be the only reason, as in 2014, anti-HEV IgG was detected in 8% of the healthy blood donors. Similarly, 1.5% of healthy donors were having viremia. Seems many things are yet unclear. Now, going to the main topic of today's presentation, the menace beyond the liver. HEV is associated with myriads of extrahepatic manifestation. In particular, neuronal, hematological, and GI abnormalities are caused by its infection. There are other organs involvement too, but the causal relation is yet to be established. The mechanism by which HEV can induce extrahepatic manifestation are largely unknown, but it may be caused by direct cytopathic tissue damage by extrahepatic replication, or it can be immunological processes that is induced by an overwhelming host immune response, or there may be some deposition of HEV antigen antibody complex in different tissues. This cartoon shows the sites of involvement of HEV and the possible mechanism. As stated earlier, it may be having direct cytopathic effect on different cell lines, triggering the immune complex, especially in the neuronal damage and deposition of antigen antibody immune complex. So this chart shows the presence of hepatitis E virus in different cells. Beside hepatocytes, HEV has been demonstrated in other tissue of the body as well as the body fluid. It has been found in human neuronal cells, placenta, as well as CSF fluid and urine. In monkey, it is found in kidney tissue. A review article has come in October this year by Fauci et al. On extrahepatic manifestation of HEV, and it has beautifully given different conditions. In this review article, 1425 articles were identified till October 2018. After exclusion, they studied 66 published articles on the occurrence of extrahepatic manifestation of HEV. The total number of various manifestations reported in their study was 324. Neurological disorders were the most common extrahepatic manifestation of hepatitis E infection, occurring about 55% of the cases. This was followed by the cardiovascular and hematological manifestation that accounted for 35%. The third common system involved was the gastrointestinal and pancreatibility system that accounted for 7%. Rarer manifestation involving systems such as renal, endocrine, dermatology, respiratory, muscular, and immune system were also reported. While neurological manifestations are more common, there are many supporting evidences. Firstly, HEV is found in CSF and there is intrathecal synthesis of anti-HEV IgG. With viral clearance, there is resolution of neurological symptoms. In vitro data has also shown that HEV can be grown in different cell lines, while in vivo experiments has shown that the HEV can pass through blood-brain barriers in animals, which may be true in case of humans also. It was shown in all studies that the HEV patient with neurological manifestation were mostly anictetic and liver functions were mildly deranged only. Neurological signs symptoms dominated the clinical pictures. Pathogenic mechanisms are uncertain, but could be due to molecular mimicry or due to direct neurotropism. HEV associated with neurological injury has been documented in both acute and chronic HEV infection with detectable HEV RNA in CSF in some cases. There is involvement of both central and peripheral nervous system. While Guillain-Barré syndrome was the most commonest occurrence, there are cases of neuralgic amyotrophic meningitis, meningoencephalitis, etc. A French study demonstrated the neurological disorder of 16.5% of HEV infected patients. Neurological manifestations were more frequent in immunocompetent patients compared to immunosuppressed patients, 22.6 versus 3.2%. In another multi-center European study, 2.4% patients of non-traumatic neurological injury had HEV infection. More than 5% at two hospitals in the UK and France between 2004 to 2009 developed neurological complications following infection with locally acquired HEV, which was genotype 3. Guillain-Barré syndrome is an acute onset immune-mediated disorder of peripheral nervous system and is characterized by acute inflammatory demyelinating polyradicular neuropathy, causing rapidly progressing systemic motor paralysis. Sood et al. Described the first case of GBS in HIV-infected individual in the year 2000. Literature search showed that 37 cases of GBS are reported in 16 case reports and 2 case control studies so far. There have been case control studies on HIV infection and GBS from the Netherlands, Bangladesh, and Japan. There is 5 to 11-fold increase in chances of GBS in HIV-infected population compared to the control. Similarly, in one Belgian study, 8% of patients with GBS were found to have HIV infection. Neuralgic amyotrophy, also known as Parsonage-Turner syndrome, is an acute and painful unique or multiple mononeuropathy in the upper extremity and is characterized by rapid multifocal motor weakness, amyotrophy, and sensory loss. It seems that HIV infection can trigger the development of amyotrophy, and several studies have been conducted. A cohort of 64 patients from UK and Netherlands found that 10% of patients with amyotrophy had acute hepatitis E infection. In an Anglo-Dutch cohort, 5 of 47 patients with amyotrophy had evidence of HIV infection at the start of their illness. Multicenter study of 118 patients with amyotrophy in Europe shows that the patient with HIV-associated amyotrophy were significantly more likely to have bilateral involvement of the more extended damage to the brachial plexus. They were also more likely to have neurological damage outside the brachial plexus, particularly phrenic nerve involvement. Dalton et al. Showed that the triad of bilateral shoulder pain in middle-aged male with abnormal LFT is highly predictive of HIV infection in the endemic region. While the other observation needs further confirmation, studies from Taiwan, China, and Germany had shown higher seroprevalence of HIV IgG in psychiatric patients. Further study is needed whether the psychiatric patients are at higher risk of acquiring HIV infection or if previous HIV infection might have triggered their psychiatric illness. Several hematological disorders have been reported in case of HIV infection. Of this, thrombocytopenia is the commonest one. Others include hemolytic anemia, aplastic anemia, and pure red aplasia. Most of these findings are published as a case reports. Asymptomatic monoclonal paraprotein has also been documented in up to 25% patients infected with HIV genotype 3, but however, the clinical significance of this observation is uncertain. Several cases of HIV-associated thrombocytopenia have been documented. In most of the cases, thrombocytopenia was self-limited, while in other cases, the patient needed platelet transfusion. A total of 17 cases have been published of severe hemolysis occurring in patients with acute hepatitis E associated with G6PD deficiency. Out of these 17 cases, 5 are reported from Pakistan by Professor Shah Abid. This may be underreported as less severe ones and the other underdiagnosed case were not reported probably. So far, 3 confirmed cases of autoimmune associated hemolytic anemia in HIV infections are already published. Hepatitis associated aplastic anemia is an uncommon but distinct variant of aplastic anemia in which pancytopenia appears 2 to 3 months after an acute viral hepatitis. The marrow failure can be severe and is typically fatal if untreated. Saha et al. Reported the case of a 32-year-old Pakistani male who developed severe aplastic anemia after a severe attack of acute hepatitis E. 3 documented cases of autoimmune associated hemolytic anemia with HIV infection has so far been published. Ecological association of viruses with acute pancreatitis is well known. Mumps and measles virus are established causes of acute pancreatitis. Acute pancreatitis was recognized as a complication of acute viral hepatitis almost half a century ago. Most of the acute pancreatitis cases are reported from Southeast Asia, where HEV genotype 1 is predominant. These cases reported from Europe had those cases reported from Europe had history of travel to Southeast Asia. No cases of acute pancreatitis have been documented in patients with acute HEV infection due to genotype 3 or 4 infection. Acute pancreatitis should be considered in patients with acute hepatitis E who develop severe abdominal pain, and similarly HEV infection should be considered as possible etiology of acute pancreatitis in area endemic for HEV genotype 1 infection. Professor Salih's group first reported acute pancreatitis in non-fulminant HEV infection in 1999 in 6 patients. Thereafter, about 50 case series plus case reports are already published. Professor Arora's group in Gangaram found that 2% of 334 acute pancreatitis cases, HEV was the etiology. A study from Rajasthan, India showed acute pancreatitis in 7 of 124 patients with acute HEV, hepatitis 3 HEV infection in West. There was significant decrease in patients infected by HEV genotype. 382 patients had acute viral hepatitis. Of 382 patients, 286 were hepatitis E, glomerulonephritis in both immunocompetent as well as immunosuppressed patient, or in cases of solid organ transplant recipient patient. In immunosuppressed patient in chronic phase infection compared to acute phase infection, LFT was done along with imaging diagnosis. 382 is supported by the fact that renal function improves and proteinuria level decreases after HEV clearance, either spontaneously or following antiviral therapy. Further, HEV RNA was isolated from cryoprecipitate obtained from a patient who developed HEV-associated cryoglobulinemia, and glomerulonephritis supplements this. In 2001, Ali et al. Reported a case of thrombocytopenia and membranoproliferative glomerulonephritis in acute HEV genotype 1 infection. No further data regarding the possible impact of HEV on the kidney were reported until 2005. Since then, renal function and histology has been assessed in a series of 51 solid organ transplant patients during genotype 3 HEV infection in West. There was significant decrease in estimated GFR rate during HEV infection, and in renal biopsy, glomerular disease were identified. Cryoglobulinemia has been observed in patients with chronically infected HEV, and it disappears after antiviral therapy. In patients with essential cryoglobulinemia, anti-HEV IgG seroprevalence seems to be high. HEV-associated cryoglobulinemia has been reported in liver transplant recipient, and they present with arthalgia, myalgia, and rashes. The prevalence of cryoglobulinemia was found to be increased during chronic phase infection compared to acute phase infection. Several other extrahepatic disorders like myocarditis, thyroiditis, Henoch-Skolin purpura, and myasthenia gravis have been described with HEV infection. HEV infection is also associated with acute polyarthritis. However, a causal relationship between these associations has not been established due to paucity of the cases. Thank you very much for the patient hearing. I'll be happy to have questions. Thank you.
Thank you, sir, for a very precise review on something which is very prevalent in this part of the world with extrahepatic manifestations. Sometimes we see a lot of patients, and it's difficult and diagnostic challenge as well. So moving on to the next speaker, and this topic, at least for me, it's very intriguing, and basically this will be by Professor Dessmond Ladden. Professor Ladden is an adjunct professor of medicine, gastroenterology, Dalhousie University, Canada. He's also the chair of Research Committee, World Gastroenterology Organization. He's a former interim chair of the Medical School, University of Limerick, Republic of Ireland. And he will be educating us about the climatic changes and implications on the liver disease. So over to you, Professor Ladden.
Hello, and thank you for joining me for this talk on climate change, the implications for liver disease. I'm Des Ladden, a professor of medicine at Dalhousie in Canada and chair of the WGO Research Committee. What I'd like to cover with you are some aspects of climate change and touch on how it relates to pollution and decreased biodiversity. Talk a little bit about the projections for Pakistan before moving on to talk about the impacts on health and liver health, propose a model and make some speculations with some examples of how climate and liver health might interact. Then we'll talk about what we can do, and I should mention up front at this point that I have no conflict of interest with regard to anything which is being presented. So at the center of this is human activity, and our activity is generating greenhouse gases which are leading to climate change. And many of the same things which generate greenhouse gases lead to pollution of the atmosphere and all of the effects which that has. This is resulting in decreased biodiversity of both macro and microfauna and decreased planetary health, and it's also adversely affecting human health. This is how the Earth's energy balance works. Energy comes in from the sun. Some of it is reflected back by clouds and by the atmosphere back into space, but some of it is absorbed by the lands and the oceans. And the wavelength of the energy changes as it's reflected back. And as the energy is reflected back, some is absorbed by the clouds, some is absorbed by the atmosphere, and much of it is radiated back into space and lost again. It essentially bounces off us like bouncing off a mirror. However, when greenhouse gases increase in concentration in the atmosphere, they're able to hold that energy in. And what happens is infrared energy is able to be absorbed by greenhouse gases like carbon dioxide and methane and others, and the infrared energy increases the kinetic energy of those gases, essentially holding that energy in the atmosphere and leading to warming of the atmosphere and resulting in climate change. It's not exactly how greenhouses work. In a greenhouse, solar energy comes in, heats the floor of the greenhouse, the infrared energy bounces up, it's reflected back by the glass, and you get warming inside here. So it's not exactly the same, but the analogy works. Now we know what the concentration of carbon dioxide has been in the atmosphere for the last 800,000 years, both from direct measurements and from ice core measurements. And this is carbon dioxide in parts per million from 150 to 400, and here are years from now, 800,000 years ago, up to the present. And you can see that carbon dioxide has indeed fluctuated over the millennia, but it has never exceeded 300 parts per million, and it is currently at 410 parts per million and rising rapidly. And it is this concentration of greenhouse gases that's forcing climate change. Now, the International Panel on Climate Change has modeled what will happen under different scenarios. And here's the temperature change from the baseline of 1971 to 1999 against the years here from 1990 to 2100, and the IPCC are plotting three different scenarios. The red one is known as business as usual, and if we stay on that pathway without reducing what we're doing, by 2100 we can expect to have a rise in atmospheric temperature of about 4 degrees centigrade. If we undertake immediate and significant mitigation, we may be able to hold that rise to 2 degrees centigrade. But we have to get on with it right now. A 4-degree rise in temperature will be catastrophic for much of the planet, and is not something we will want to contemplate. The IPCC also produces maps of temperature change and precipitation change, and let's have a look at those. This is the temperature change at 1.5, what will happen by location at 1.5 degrees centigrade of warming. Darker colors are warmer, lighter colors are less warm. And you can see here that the oceans are warming less than the landmass, which makes sense. They're able to buffer that temperature rise. The Arctic is rising faster than any place else. And if we look at Pakistan, you can see that there's a very significant rise in temperature over Pakistan at both the 1.5 degrees centigrade warming, and it's even more pronounced at 2 degrees. If we look here at precipitation at 1.5 degrees of warming, dark blue means more precipitation, darker red means less. You can see a band of drought coming across southwestern United States, Central America, West Africa, right through the Mediterranean and reaching out towards Afghanistan and Pakistan. And at 2 degrees of warming, that gets even closer to you with a very significant decrease in precipitation to the west of Pakistan and some signal that there may be an increase over parts of Pakistan. Climate change and pollution are related in a number of ways. This shows the percentage of households with access to clean sources of cooking, and you can see that for most of Africa, it's less than 25% of households. And similarly, in India and Pakistan, it's less than 25%. So people are burning fuels for cooking and for warmth that are both causing pollution and changing the climate. They travel together. Another effect is on biodiversity, and it's estimated that there's been a 70% reduction in megafauna, that's big animals, since 1970 in species which have been followed. And there may be similar changes in macrofauna and in the microbes in the very soil which we rely on for nutrition. And that's happening on land and on the oceans. The consequences are a loss of biological control. It's not too difficult to draw a line between the COVID pandemic and the changes that we're making on the planet. And there may be an increasing disease risk. So if you think of Clostridium difficile, for example, an organism which lives in the gut and normally doesn't cause any trouble until you eradicate the normal flora around it, and then it does cause pathology. So that may be similar to what may happen with the planet as we decrease biodiversity. So moving on to health, you can see a very direct line between climate change and health effects. So increasing carbon dioxide levels in the atmosphere are leading to rising temperatures, more extreme weather events, and rising sea levels. Let's see how this works. Severe weather can cause direct injury, of course, and fatalities and mental health impacts from stress, but it can also damage the hospital infrastructure which we need to deliver care. Air pollution is related to asthma and cardiovascular disease. Changes in vector ecology are related to malaria, and dengue, and other viruses. Increasing allergens as a result of a longer growing season and warmer climate. It's associated with respiratory disease and asthma. Decreased water quality is associated with an increased risk of cholera, cryptosporidiosis, leptospirosis, hepatitis A, and hepatitis E, and harmful algal blooms. And of course, a decreased water and food supply impact results in malnutrition, diarrheal disease, and forced migration with civil conflict and mental health impacts. And that's leaving aside the direct effects of heat-related illness and death from cardiovascular disease. So that's the general effects of climate change on human health. What about climate change on the gut? Well, the main effects we can anticipate: water security, increased high rainfall events with flooding and enteric infections and hepatitis, and drought is also associated with an increased risk of infections. There'll be a change in disease patterns, increased migration, and infrastructure loss from increased severity of storms. Migration may be partly between countries, but you can anticipate there will also be an increase in the size of cities as people move from rural areas. Well, what about liver disease? In reviewing the literature, I cannot find any definite signal linking climate change, pollution, and biodiversity to changes in congenital or genetic or autoimmune or metabolic liver disease. Probably an argument could be made. I simply have not found that in the literature. However, you can draw clear lines between carcinoma of the liver, climate change and pollution, infections of the liver, toxic exposure of the liver, and changes in the burden and delivery of liver care with climate change and the pollution. So, for example, if we look at infections, there are clear signals around hepatitis A and E, Fasciola, Clonorchis, schistosomiasis, leptospirosis, milidiosis in Australia and Brucella, and the vector mosquitoes. And of course, we have to keep in mind that there may be novel diseases that we don't know about yet. This is the life cycle of Fasciola. It involves water and animal husbandry and exposure of humans. It's very easy to see how changes in climate and rainfall events could lead to a change in fluke distribution. With regard to toxins, one of the best known, of course, is the aflatoxin, and clear links to climate change. Crop stress makes the crops more susceptible to infection with Aspergillus. Storage in hotter and wetter environments and eating more marginal foods will expose people to mycotoxins, and there is a link to liver disease, although I'm not sure of exactly the magnitude of that link. It's hard to say. Harmful algal blooms result from overnutrition of water, intense nutrient pollution, and reduced soil diversity, and a number of toxins can be produced, including from cyanobacteria. Their liver failure was reported from contaminated dialysis water with cyanobacteria, but I'm not sure what the effect is of chronic low-level exposure to these toxins. They may play a role, but it's not clear to me. With regard to infrastructure loss, this has been mapped for Pakistan. The Red Crosses are hospital facilities, healthcare facilities, that are at high risk of damage from flooding. And you can see that there are many, many of these throughout Pakistan, following the route of the river. And of course, these hospitals being susceptible to damage will make it very difficult for them to function. And that's probably one of the main links to the impact on liver cancer. So infections may contribute, as may exposure to toxins, as we discussed. But infrastructure damage will certainly interfere with prevention, detection, diagnosis, treatment, and survivorship from liver cancer. Migration, Pakistan already has a significant number of migrants. The area to the west of you is likely to become more dry and conditions more difficult, and may force more migration towards Pakistan. So it may have a very significant impact on the burden of liver disease in Pakistan, because many of these migrants have infections with hepatitis B or HCV. So if we were to put up a model then of how climate change might intersect with liver disease, we could say, well, if we look at infectious disease, malignancy, and toxic liver disease, rising temperature may lead to changing vectors and changing habitat. Rising temperature may lead to increased aflatoxin, cyanotoxin, and aflatoxin production, with resulting liver impacts. Increased rainfall and floods will be associated with hepatitis A and E. Structural and liver damage will intersect with malignancy, and increased rainfall and floods results in more chemical pollution and more exposure of the liver to toxins. Similarly, drought causes water stress and migration. Exposure to toxins and concentrates infectious and toxic agents. And extreme weather causes structural damage, and structural damages perhaps with toxin release. What can you do? Well, whatever you can do. I think the most important thing at this point is to educate yourself and try to get this in the your national society in putting this forward as an issue for discussion. Advocate for change and talk to your peers and politicians, and it's especially important to support politicians as they try to make these changes. Why should you do it? I can think of 5 reasons. It might make a difference. It might be very important medical care. I suspect it is. It'll encourage others to join in, and it'll support your political leadership who have to make tough choices on this. And importantly, you will be able to look the next generation in the eye and say that you did something when you were aware of it. So in summary, climate change and pollution are affecting biodiversity and health. The liver is susceptible to this, and healthcare providers need to act on this. Thank you to the organizers for inviting me to speak to you and for your attention on this talk. I hope it's been of useful to you and that it will help you as you move forward with this difficult issue. Thank you very much.
Thank you, Professor Ladden. This was an excellent talk, and I'm sure people who have listened to this would gain
Unmuted.
a lot because unknowingly we do a lot of things, and actually that is creating the climatic change, and diseases like infections and malignancies are on the rise. So we move on quickly to the next talk, and this is by Professor Dong-Joon Kim, sorry, apologies. Professor Kim is a professor of Department of Medicine, Hallam University College of Medicine, South Korea. He's also director, Institute of Liver and Digestive Diseases, Hallam University, and K Research Institute, South Korea. And Professor Kim would update us regarding the management of alcoholic-associated liver diseases. Can we have Professor Kim's presentation, please?
Dear colleagues, 40 years ago, there was no hepatitis B vaccine, and we did not know about hepatitis C virus itself. At present, highly active oral NUCs and DAAs are widely used. 40 years ago, we used prednisolone to enhance short-term survival of alcoholic hepatitis. However, still at present, management of severe alcoholic hepatitis can challenge even experienced clinicians. Reference guidelines or guidance of this talk are 2018 EASL Guidelines, 2018 American College of Gastroenterology Guideline, and 2019 AASLD Practice Guidance. These 3 guidelines are not so different. I will briefly summarize EASL guidelines and compare other guidelines with EASL guidelines if necessary. EASL use grade system, ACD use both grade and expert opinion. However, AASLD guidance is a consensus-based one. Since the term alcoholic is stigmatizing and undermines patient dignity, it is recommended to use alcohol-related or alcohol-associated liver disease instead of alcoholic liver disease. There has been discrepancy in the definition of a standard drink, varying from 8 to 16 grams. WHO and EASL define a drink as 10 gram pure ethanol, US dietary guidelines as 14 gram. Heavy episodic drink has been defined as consumption of more than 60 gram of pure alcohol on one occasion. Binge drinking is the consumption of 4 or more drinks for women and 5 or more drinks for men within 2 hours. The injurious effect of alcohol on the liver is not linearly dose-dependent, but there is a threshold beyond which the risk of serious liver disease increases. According to the U.S. dietary guidelines, which are adopted in CDC homepage, if alcohol is consumed, it should be consumed in moderation, up to 1 drink per day for women and 2 drinks per day for men. However, in the aspect of public health, based on weighted relative risk curves for each health outcome associated with alcohol use, the level of consumption that minimizes health loss is 0. The cardioprotective effect of alcohol is abolished by the increased risk of cancers. Importantly, there is good clinical evidence that cessation of drinking at any point in the natural history of cirrhosis reduces the risks of disease progression and occurrence of complications. So, patients with liver diseases should be counseled that there is no safe level of drinking and that they should abstain. Alcohol hepatitis per se is a clinical syndrome. In addition, liver biopsy cannot distinguish between alcoholic steatohepatitis and NASH. The consensus statement, which was intended to improve consistency in diagnosis of alcoholic hepatitis, proposed clinical diagnosis criteria with serum bilirubin 3, AST/ALT elevation, history of heavy alcohol use, and exclusion of other liver diseases. Both of American guidelines, but not in Israel guidelines, proposed definite, probable, and possible AH subtypes. As biopsy-proven definite alcoholic hepatitis, clinically diagnosed probable AH, which may be associated with only a low rate of histologic misclassification and therefore biopsy may not be essential, and clinically suspected possible AH, which should undergo liver biopsy to confirm the diagnosis. As the measurement of indirect alcohol markers such as GGT, AST/ALT, and MCV have low specificity and sensitivity, Israel guidelines recommend the direct alcohol markers, including ethyl glucuronide, ethyl sulfate, phosphatidyl ethanol, and fatty acid ethyl esters, which have a much higher specificity in comparison to direct determination of ethanol in blood or exhaled air. They have a much longer detection window, which is often critical in order to uncover alcohol intake. Today, determination of ethyl glucuronide in urine is widely applied in many European countries for regular monitoring of patients. Determination of ethyl glucuronide in the scalp hair is a powerful tool for monitoring long-term abstinence over a period of up to 6 months. Urine ethyl glucuronide and phosphatidyl ethanol are commercially available for use in routine clinical practice in the United States. In 2018 ACG guideline, baclofen is recommended in patients with ALD to prevent alcohol relapse with low level of evidence. Different prognostic models have been developed which aim to identify patients at high risk of early deaths. It is recommended that available prognostic scores should be used, including the Madrid Discrimination Function Score, MELD score, Glasgow score, AVIC score, and Lille score. Recently, maturing group suggested the MELD plus Lille combination model provide a continuum of mortality risk from 0% to 100% rather than a simple yes or no response, allowing for a more nuanced prediction of outcome, particularly in patients with intermediate risk. In relation to resistance to corticosteroid, the joint effect model identifies a high risk of death in patients previously classified as responders and an intermediate risk of death in patients who previously classified as non-responders. Defining severe alcoholic hepatitis is not consistent. 2018 Israel guidelines use MDF-32 or Glasgow score 9, 2019 AASLD guidance and 2018 ACG guidelines use MDF-32 or possibly MELD-20. In 2018 ACG guideline, therapies are classified as with proven potential and no efficacy, corticosteroid as with proven efficacy, and pentoxifylline as with potential efficacy. Of note, in 2019 AASLD guidance, only abstinence is as having proven effect. Corticosteroid is classified as likely benefit, not as proven efficacy, and pentoxifylline is as unlikely benefit, not as potential efficacy. The management of alcoholic hepatitis is straightforward at large: clinical diagnosis, nutritional support, evaluation of severity. If severe, use corticosteroid. If respond early to corticosteroid, continue it, and if not, consider liver transplant. The STOPA trial was conducted in the UK in order to resolve the controversy over the use of corticosteroid or pentoxifylline. Conclusions are: pentoxifylline did not improve survival. Prednisolone was associated with a reduction in 28-day mortality that did not reach significance and with no improvement in outcomes at 90 days or 1 year. Currently, there is a general agreement that corticosteroids should be part of first-line therapy in patients with alcoholic hepatitis. Pentoxifylline is not recommended as a first-line therapy. In a French cohort, 1/4 were infected at the time of admission, with another 1/4 developing infections during steroid treatments. Given corticosteroid-associated risks, it should be started with a low clinical suspicion of infection and a lack of other contraindications, including AKI, GI bleeding, and acute pancreatitis. When cultures reveal an infection, steroid may be started after 48 hours of treatment with appropriate antibiotics. For stopping corticosteroid therapy, early identification of non-responders to corticosteroid is important to stop unnecessary exposure. The Lille score should be calculated after 7 days of steroid use. If the score is equal to or greater than 0.45, particularly in non-responders defined by Lille score 0.56, steroid therapy should be stopped. Also, if any complications of severe alcoholic hepatitis develop, particularly infection and AKI, corticosteroid should be stopped. Stopping rule of corticosteroid using Lille score at day 7 is shown here. A multi-center French trial compared the effect of the combination of prednisolone and N-acetylcysteine. Mortality at 1 month was significantly lower in the PD plus N-acetylcysteine group compared to the PD-only group. Importantly, the instance of hepatorenal syndrome and infections were significantly reduced. Therefore, the combination of PD plus NAC appear to improve prognosis of patients with severe alcoholic hepatitis. N-acetylcysteine can be added to prednisolone therapy as shown here. Infection is a frequent and severe complication in patients with severe alcoholic hepatitis and is one of the major causes of death. At admission, SBP or spontaneous bacteremia occurred more frequently, followed by UTI, while during or after corticosteroid treatment, respiratory infections became important. Therefore, systematic screening for infection should be performed before initiating therapy, during corticosteroid treatment, and during the follow-up period. Patients with severe alcoholic hepatitis are at risk of developing AKI, which negatively impacts survival. Patients with AKI should receive diligent care to identify and reverse precipitating factors and improve renal function. They include avoidance of diuretics and nephrotoxic drugs and volume expansion with albumin or saline infusion if needed. Renal replacement therapy is recommended in AKI in the presence of sepsis-associated ATN or if the cause of AKI is unclear. Maturin and colleagues reported a multi-center European trial of early liver transplant in patients with alcoholic hepatitis non-responding to medical therapy. This landmark study demonstrated an unequivocal survival benefit of early transplant for severe alcoholic hepatitis compared to controls. This study on early transplant challenges previous expert opinion, which considered alcoholic hepatitis as a contraindication for liver transplant. Until very recently, patients with alcoholic hepatitis were not considered appropriate candidates for transplant, mainly on account of a lack of 6 months sobriety period to liver transplant. But this 6 months rule has limited evidence, and UNOS ILTS did not endorse the 6 months rules. So the decision on LT evaluation should not be based solely on 6 months of alcoholic abstinence. The conviction alcoholism is self-inflicted must be reconciled with the strong evidence supporting genetic and environmental influence on AUD. Physicians should have empathy on alcoholism as a disease and not behavior. It is recommended that early liver transplant should be proposed to patients not responding to medical therapy after a careful selection process. ALD is now a leading indication for patients undergoing liver transplant in the United States, suppressing HCV infection. Advances in the understanding of molecular mechanisms of ALD have yielded the identification of new therapeutic targets, including inhibition of the interleukin-1 pathway with receptor antagonist canakinumab and monoclonal antibody canakinumab, inhibition of inflammation with CCL2 and CCL5 inhibitors, chaniclibilog, microRNAs, and extracellular vesicle targets, G-CSF to increase hepatic regeneration, and therapies targeting intestinal dysbiosis such as FMT and bacteriophage therapy. However, there are more questions than answers. I would like to conclude it with this. According to a traditional liver-centered view, liver has been considered as the main victim of the harmful use of alcohol. But AH should be considered as a true systemic inflammatory disease not limited to the liver. The importance of comprehensive screening for and surveillance of infections could not be overemphasized. Prevention of infections and AKI is better than treatment. Meticulous, diligent, and multidisciplinary care are mandatory. Physicians' empathy on alcoholism as a disease and not behavior. If feasible, consider early liver transplantation. Thank you for your attention. I hope to see all of you in 2022 in Seoul.
Can you hear me? Yes. Thank you, Professor Kim, for the excellent talk on alcoholic-related liver diseases. So we move on to the fourth talk of this symposium, and this is by Professor Mohammed Alboraie. Professor Borai is a consultant internal medicine, gastroenterologist, hepatologist at Al-Azhar University in Cairo, Egypt. He is also the chair of International Relations Committee, Egyptian Association for the Research and Training in Hepatogastroenterology, and Professor will be speaking regarding the management of cirrhosis and portal hypertension in pregnancy, which is another important topic related to hepatology. Over to you, sir.
My topic today will be about managing cirrhosis and portal hypertension in pregnancy. Our agenda today will be a brief introduction, management outlines, managing cirrhosis in pregnancy, managing portal hypertension in pregnancy, and take-home messages. Liver disease in pregnancy are either unique diseases occurring during pregnancy, like hyperemesis gravidarum and preeclampsia and eclampsia, etc., or an acute or chronic liver disease which could be pre-exist before or occur coincidentally during pregnancy, like viral hepatitis, cirrhosis, and portal hypertension, etc. This is the full list of pregnancy-related liver diseases and non-pregnancy-related liver diseases. In this topic, or in this talk, we will focus on cirrhosis and portal hypertension. Cirrhosis and portal hypertension can complicate pregnancy and increase both maternal and neonatal morbidity and mortality. Because of the historically high maternal mortality, pregnancy was discouraged in patients with cirrhosis or portal hypertension. However, with the current therapy and intensive monitoring, these medically complicated pregnancies can have favorable outcomes. Although previously reported to be as high as 10.5%, maternal mortality has slightly improved along with better management of liver failure and variceal hemorrhage. Nevertheless, morbidity and mortality remains higher than that of the general pregnant population. It's important for physicians caring for pregnant patients with cirrhosis to understand how to approach potential complications and tailor medication regimen appropriately. Women known to have esophageal varices appear to be at the highest risk. Other maternal complications can also occur. This includes anemia, postpartum hemorrhage, preeclampsia, placental abruption. Fetal complications also, including miscarriage, preterm delivery, and intrauterine growth restriction can happen. So considering both maternal and fetal health is crucial for choosing diagnostic strategies and therapeutic modalities. And provision of optimal care for mother and fetus usually requires management by a team composed of obstetrician, hepatologist, anesthesiologist, surgeon, nutritionist, and hematologist. The management outlines is composed of management before pregnancy and during pregnancy and in late pregnancy and labor. So before pregnancy, we have to assess liver functions, portal hypertension, and to calculate MELD score. And it's important to know that patients with MELD score more than 10 have high maternal risk and poor outcome, and this has to be mentioned clearly to the patient. Nutritionist consultation to maximize nutrition and replace fat, soluble vitamins, and minerals is also important. Also, endoscopy for screening for varices is crucial to do either before pregnancy or maybe in the second trimester to prevent variceal hemorrhage during labor. During pregnancy, we have to manage those patients by a high-risk team, and we have to have frequent visits for those patients with monthly laboratory investigations, including CBC, INR, albumin, ALTs, bilirubin, etc. And we have to continue the beta blockers if they are taking before pregnancy and other medications if proven to be safe during pregnancy. We have also to monitor the nutritional status, and we have also to consider upper endoscopy if not done before pregnancy, and if the varices is large or risky, we have to do band ligation. During the third trimester and delivery, there will be a high-risk team planning for the delivery also, and we will monitor coagulopathy, monitor the nutritional status, and we have also to operation and replace fat, soluble vitamins and minerals also important. Also, endoscopy for screening for varices is crucial to do either before medications and tailor medication regimen for miscarriage, preterm delivery, and intrauterine growth restriction can happen. So considering both maternal and fetal health is crucial for choosing diagnostic strategies and therapeutic modalities. And provision of optimal care for mother and fetus usually requires management by a team composed of obstetrician, hepatologist, anesthesiologist, surgeon, nutritionist, and hematologist. The management outlines is composed of management before pregnancy and during pregnancy and in late pregnancy and labor. So before pregnancy, we have to assess liver functions, portal hypertension, and to calculate MELD score. And it's important to know that patients with MELD score more than 10 have high maternal risk and poor outcome, and this has to be mentioned clearly to the patient. Nutritionist consultation to maximize nutrition and replace fat, soluble vitamins and minerals is also important. Also, endoscopy for screening for varices is crucial to do either before pregnancy or maybe in the second trimester to prevent variceal hemorrhage during labor. During pregnancy, we have to manage those patients by a high-risk team, and we have to have frequent visits for those patients with monthly laboratory investigations, including CBC, INR, albumin, ALTs, bilirubin, etc. And we have to continue the beta blockers if they are taking before pregnancy and other medications if proven to be safe during pregnancy. We have also to monitor the nutritional status, and we have also to consider upper endoscopy if not done before pregnancy, and if the varices is large or risky, we have to do band ligation. During the third trimester and delivery, placenta abruption. So if spontaneous bacterial peritonitis occurred, we have to treat it with antibiotics like third-generation cephalosporin. Pregnant patients with cirrhosis can also develop hepatic encephalopathy if they are predisposed to a medication that precipitating encephalopathy, or if they experience hypotension, hypoxia, and infection, hypoglycemia, etc. The mainstay treatment remains lactulose, which is safe during pregnancy, and antibiotic therapy if needed. Of note, spinal and general anesthesia should be avoided during delivery because of the potential risk of hypotension and precipitation of encephalopathy. These are the medication used in patients with liver disease. We have to be aware of the FDA pregnancy category of these drugs, like most of them are category C, but we have some of them category B, like octreotide and lactulose and cefotaxime or third generation cephalosporins. And we have also to know that these drugs has an effect on the mother and effect on the fetus, and we have to avoid some of them. Pregnant patients with cirrhosis have an increased risk of splenic artery aneurysm rupture, which is occurring in 2.6%. The risk of fetal malformation from radiation is thought to be increased at doses above 150 milligray and is considered negligible if doses are below 50 milligray, which equals to 500 rad. Few case reports of TIPS placement has been reported in pregnant patients with cirrhosis and all survived the episode of variceal bleeding. Looking into surgery like surgical creation of splenorenal or portocaval shunts has also been advocated based on observational studies showing that women with cirrhosis and shunts have a lower risk of spontaneous abortion compared to women without shunts, and has a 7-fold lower risk of severe gastrointestinal hemorrhage. However, surgical shunt procedures are generally performed only in the setting of life-threatening hemorrhages, and this is life-threatening hemorrhage that is refractory to medical and endoscopic treatment. Many experts also advocate using elective cesarean section or forceps-assisted delivery under extradural analgesia in order to decrease the risk of variceal hemorrhage. Although this seems reasonable, no randomized controlled trials have been performed to support this recommendation. If cesarean section is performed, a vascular surgeon should be available in the event that bleeding from pelvic or abdominal wall collaterals is encountered. Finally, my take-home messages. Improvement in treatment of cirrhosis have resulted in increased pregnancy occurrence and outcome. Physicians need to become aware of the unique risks and complications related to pregnant women with cirrhosis. Potential life-threatening variceal bleeding, hepatic decompensation, splenic artery aneurysm rupture, and postpartum hemorrhage are the most common complications. Monitoring and counseling is crucial to achieve favorable outcome for both mother and fetus. Medications may need to be adjusted during this time period, as several drugs commonly used for liver disease have potential harmful effect on the fetus. Multidisciplinary team is needed to ensure better outcome for both mother and baby. Thank you very much.
Thank you, Dr. Alboraie, for shedding light on a very important topic. Our next speaker is Dr. Mohammed Salih. Dr. Salih is Director Hepatology and Consultant Gastroenterologist and Hepatologist at the Quaid-e-Azam International Hospital, Islamabad, Pakistan. And he would be speaking about yet another important topic, and that is vascular thrombosis in cirrhosis, when and how to manage with anticoagulation. Can we have Dr. Salih's presentation, please?
Assalamu alaikum. I'm Dr. Mohammed Salih and will be presenting on this important topic of vascular thrombosis in cirrhosis. And I'm really glad and thankful to the organizing committee that has given me the opportunity to talk on this important topic, when and how to manage anticoagulation. No disclosures regarding this presentation. The question is that are cirrhotics at risk of thrombosis or coagulation? Well, contrary to the routine understanding or the concept that they are anticoagulated automatically, rather the cirrhotics are on aggregate procoagulant or in a hypercoagulable state, more so when the portal hypertension increases or worsens. And the recent data have correlated increased productions of von Willebrand factor in patients with cirrhosis, more so when there is worsening of ascites, bacterial infections, increased incidence of variceal hemorrhages, and the overall and worsening of the overall transplant-free survival rate. So this von Willebrand factor also increases, and the overall outcome without transplant is worsened as the portal hypertension and the cirrhosis worsens. The balance between hemostasis is basically between the procoagulants and the anticoagulants, and that's how our blood flows and stops flowing when there is a need. However, there are certain factors which would lead to more bleeding, and there are certain factors which would lead to more thrombosis. And this is basically an elaborative form of that if there is thrombocytopenia, platelet dysfunctions, low coagulation factors, dysfibrinogenemia, and even elevated TPA levels, and if they are there, so there will be more bleeding. On the contrary, if there is deficiency of certain factors like protein S and C, low levels of plasminogens, or elevated von Willebrand factors, so there will be, these factors will promote thrombosis. And this is well depicted in this cartoon, that it's not only the total quantity, it's basically the balance between prothrombotic factors and the coagulant and prothrombotic factors and anticoagulant factors. And that's how, even in cirrhosis, when their concentration goes down, on the contrary, or at the same time, the concentration of the other factors also goes down, and that's how this balance is maintained. And even at times, we may see prolonged INR or prolonged prothrombin time. Still, the patient may be procoagulant, and this we see more so when we apply other methods of checking coagulation profile like thromboelastography. The venous thromboembolism in cirrhosis. Interestingly, the incidence of venous thromboembolism in cirrhosis is not decreased compared to those without cirrhosis. In fact, population-based data report increased relative risk of vascular thromboembolic phenomena in cirrhosis, and the cumulative odds ratio for such events in patients with cirrhosis is even more than without cirrhosis. So, while there are no data to guide specific strategies, there is no evidence that prophylactic anticoagulation is associated with increased bleeding complications in cirrhotic patients. So, even if you anticoagulate them for whatever reason, the chances of bleeding-related complications are not increased in cirrhotics. We know that thrombosis in cirrhosis is categorized into so many, I would say, there could be etiology leading to cirrhosis like Buerkeri syndrome, or cirrhosis with portal vein thrombosis, or even cirrhosis with malignant thrombosis. That is the tumor invasion of the portal vein and hepatic vein. Today, we will be discussing touching upon only on the venous thromboembolic phenomena and only portal vein thrombosis due to shortage of time. We're not discussing the diseases like Buerkeri syndrome or malignant thrombosis. The portal vein thrombosis in cirrhosis is the most common vascular thromboembolic event, and with the increased rates in the setting of specifically decompensated cirrhosis. And the incidence ranges at 1 year 5%, while it may reach up to 40% at 10 years. And the higher incidence rate is more so with NASH-related chronic liver disease, and as the hepatocellular failure advances or with advanced liver disease. Now, who are at risk for portal vein thrombosis? If there are prior vascular thromboembolic phenomena, patients with thrombophilia, low portal vein velocity, malignancy, and hepatocellular carcinoma, even without direct invasion of the tumor, but whenever we see a vascular thrombus, we do screen them for malignancy, or more so for hepatocellular carcinoma, intra-abdominal infections, and any recent interventions. So these are those risk factors which would place our patients for portal vein at risk for portal vein thrombosis. The presentation is variable, and the stability, regression, resolution appears more common than clot progressions. And cirrhotic patients with portal vein thrombosis and no other vascular thromboembolic phenomena history, they do not require hypercoagulable or prothrombotic workup. So this is very important to understand. The prognosis, there is controversy whether non-malignant portal vein thrombosis impacts prognosis or not. However, one thing is sure, that definitely these vascular thromboembolic phenomena leads to technical complexity of transplant surgery and may have negative impact on transplant outcomes. So once these patients develop thromboembolic phenomena, portal vein thrombosis, they are having advanced disease, and the outcome may be at times challenging. Before starting anticoagulation, what we should be doing, just like we should be doing in all cirrhotics, patients with cirrhosis and portal vein thrombosis should be assessed for the presence of varices and dealt with accordingly. The chances of bleedings are lower on anticoagulation as compared to no treatment. So while there is a tendency in understanding that these patients may bleed more if we give them anticoagulants. However, this is not true. The treatment is usually with the low molecular weight heparin, and this appears safe and effective in portal vein thrombosis and the cirrhotic patient. Can we give oral therapy? Yes, why not? The time-tested warfarin is there, and even the directly acting oral anticoagulants can be used, and they even appear a little or to somewhat superior to warfarin, more so with improved overall survival rates. So we can treat them with the low molecular weight heparin, with warfarin, or with direct acting oral anticoagulants. When to treat portal vein thrombosis, the decision to intervene rests on few factors like the extent of thrombosis, the presence or absence of attributable symptoms, risk of bleeding and falls in the patient. When we should be treating portal vein thrombosis? The guidance exactly is lacking as there is less data available. However, treatment is indicated more so in liver transplant candidates due to adverse effects of the portal vein on technical aspects of transplantations. So whenever there is portal vein thrombosis and the patient is a future candidate for liver transplantation, one may treat these patients, or one should treat these patients. Now, what happens if we come across an acute portal vein thrombosis? Heparin infusion can be used in the hospital setup. However, if the patient is dealt as an outpd patient on an outdoor patient basis, or after the hospital setup, may switch to a low molecular weight heparin if tolerated, or maybe even managed on directly acting anticoagulants in compensated cirrhotic patients. The duration of therapy, anticoagulations may produce change in portal venous thrombus volume on imaging as early as 2 weeks. However, the duration for which we give these agents should be somewhere between 3 months to 12 months. And 71% would achieve at least partial recanalization, and half or more, a little more than that, would completely recanalize after approximately 6 months of treatment. So somewhere between 3 months to 12 months therapy is required. Now, if there is incomplete resolutions of the thrombus on anticoagulation, the treatment option would include either you extend the therapy, switching to a different class of therapeutic anticoagulants, and even at times we may require interventions like transarticular intrahepatic photosystemic shunting. Can prophylactic therapy be considered in cirrhotic patients to avoid portal vein thrombosis? Yes, there is some data available in a prospective trial of enoxaparin therapy for patients without portal vein thrombosis, and they found that there was low incidence of portal vein thrombosis, decreased incidence of decompensation, and even improved overall survival. So one can make a case of prophylactic anticoagulation as well. So the take-home messages would be cirrhosis is rather a procoagulant condition, so one should be very watchful. Patient at risk for DVT may be prophylaxed. Screening endoscopy should be performed before anticoagulation is started, and liver transplant candidates should be anticoagulated because this may add to the complexity of the transplant surgery. And low molecular weight warfarin are directly acting oral anticoagulants or the treatment options. Cirrhotic patients are at low risk of portal hypertension related bleeding when they are in anticoagulation. Rather, they would bleed more if you do not anticoagulate them. So, portal vein thrombosis is a relatively not so uncommon phenomena and should be considered and treated in the light of these data which are available to us. Thank you all for your kind listening.
Thank you, Dr. Saleh. Indeed, a very debatable topic, and I think you have summed it up very well. You've talked about all the aspects, and it's always a great treat to listen to you. Well, we move on to our last topic, and that is also a very important and important topic in hepatology, and this will be presented by Professor Ananta Sharesta. Professor Sharesta is a consultant hepatologist in the Department of Hepatology, Liver Foundation, Nepal, Kathmandu. He is also secretary of Nepalese Association for the Study of Liver, executive committee member of the South Asian Association for the Study of Liver Disease. And he would be speaking about diet and exercise in NAFLD and what to tell our patients about this. Professor Sharesta, please upload his slides. Thank you.
Ladies and gentlemen, a very good evening. Greetings from Kathmandu. In the next 15 minutes, I'll be talking about diet, exercise, and weight loss in management of NAFLD. I have nothing to disclose, and these are my talking points. As we all know, with the data from population-based cohort studies, NAFLD patients tend to survive less as compared to the reference populations. And when you see the cause of death in these patients, major cause of death in these patients are cardiovascular death, followed by non-liver-related cancers, and then which is followed by a liver-related. It's very important to understand that fibrosis is a surrogate for a long-term outcome in NAFLD patients. It's again very important to understand that fibrosis is one of the endpoints while evaluating the efficacy of any pharmacological therapy or lifestyle modifications. Now, the data have shown that fibrosis directly is associated with the mortality rates in all-cause mortality in patients with NAFLD. So more you have fibrosis, the more the risk of dying because of anything. It could be liver-related mortality or extrahepatic mortality like cardiovascular health. This is even more true when it comes to liver-related diseases. So survival free transplantation or liver-related mortality is shown to be better in patients who don't have fibrosis compared to those who have fibrosis. And there are many other surrogates or histological features like portal inflammation, NASH, and ballooning, but they don't tend to do as good as fibrosis in terms of predicting the overall long-term outcome. So while managing the patient with NAFLD, it is very important to understand and realize that most of these patients would die because of cardiovascular death rather than liver-related death. So just merely targeting liver-related health or liver-related outcomes will not help to improve overall survival. So there should be an attempt to reduce cardiovascular risk, address obesity, dyslipidemia, and overall metabolic risk factors, and also reduce the liver-related mortalities. So currently available pharmacotherapy focus on liver-related health. There have been few therapies that have been approved and few more which are under the trials and have shown promising results in improving hepatic steatosis and resolution of NASH. But when it comes to improvement in fibrosis, which is again a very hallmark feature and is a surrogate marker for overall long-term outcome, there are very limited drugs that have shown promise. And among those drugs that have shown promise, the margin of benefit is again very, very slim. And it's very important to understand that drugs used for NAFLD are usually liver-centric. The endpoints are histological, not survival-based, and the data in fibrosis regression is sparse. So it is understandable that the treatment of NAFLD is probably going to stick to lifestyle modification, which is the cornerstone for therapy as of now, and probably is going to remain for a few decades more. Lifestyle modification constitutes of weight loss, which is the most important factor. It could be the second pillar is diet, and third is exercise. And this can be achieved independently or maybe achieved in conjunction with each other or maybe complemented to each other. Now, coming to weight loss, very beautiful review has shown that weight loss is directly related to resolution of NASH, fibrosis, as well as hepatic steatosis. More you lose weight, these benefits are greater. And if you tend to lose more than 10% of your weight, this regression of fibrosis is about 81%. Now, this much of fibrosis regression is not offered by any form of modern pharmacotherapy. So if there has to confer any benefit in patient with NAFLD and NASH, somebody has to lose more than 7% of their body weight. But again, the drawback of lifestyle modification is nearly about 20% of this patient can achieve weight loss more than 7% of their baseline body weight. Whereas, rest of the 20% of this patient probably will not be able to achieve the desired amount of weight loss. Now, coming to dietary intervention, it is known that dietary intervention is known to reduce hepatic fat and improve cardiovascular risk independent of weight loss. When it comes to regression of fibrosis, dietary interventions cannot regress fibrosis unless and until weight loss is achieved. So weight loss is very important to achieve regression of fibrosis, and it is now known that hypocaloric diet, if it is followed for about long term, does help in reducing weight and achieve reduction of fibrosis. So dietary intervention can be done with various approaches. The first approach is to alter calorie content or reduce the calorie content, to be very specific. Second is altering the macronutrient composition while keeping the calorie content same. And third is changing the eating pattern. Now, when you tend to alter calorie content, it is usually reducing the calorie about 500 to about 1,000 kilocalories below the daily requirements. And this is usually done by cutting down the simple carbs or fructose or glucose and introducing complex carbohydrate. Some emphasize in reducing carbohydrate content and increasing fat. Others use high carbohydrate content and reduce fat. And some have introduced about high protein diet. When it comes about isocaloric diet or altering the macronutrient composition, Mediterranean diet is quite popular. It is rich in monounsaturated fatty acid. It's got whole grains, fish, wines, and it cut down simple sugar and carbohydrates. Ketogenic diet is getting popularity and basically is based on high fat and low carbohydrate diets, which we'll be discussing later on. There are some other high protein diet regimens as well. Now, as long as the diet is hypocaloric, it really doesn't matter if it is low fat or high fat. If it is isocaloric diet, it always has to be low fat. If it is high fat diet and low carb diet, it tends to increase liver fat. And second thing is, it is very important to realize that the quality of fat does matter. Low saturated fatty acid in high PUFA diets tend to decrease liver fat content. So does high MUFA content as well. So monounsaturated fat and polyunsaturated fat, if it is rich, then it tends to improve liver status. So keto diet is getting increasingly popular these days. And the basic idea of keto diet is replacing the carbohydrates with the fat. You can see this is the normal dietary contribution of fat, protein, and carbohydrate. And here the composition of keto diet is the carbohydrate is markedly reduced, and which is most of the proportion of the carbohydrate is replaced by the fat. It has been shown that, with keto diet, people tend to lose total weight, total fat content, as well as water content, but while maintaining their total muscle mass as well as bone. So it also has some beneficial effect on the liver fat content. It tends to decrease, with about 14 days of intervention. And there are some preliminary data that the keto diet or low carbohydrate and high fat diet tends to improve the microbiota profile and towards a favorable one. Problem with calorie restriction is the sustainability. In the clinical trials, it's shown that when they're given intense lifestyle modification and calorie restriction, they tend to lose weight, but again, they're not sustainable. They tend to gain weight over due course of time, and the BMI and the body weight tends to rebound back to normal. Usually results because of when you reduce the calorie consumption, there's decrease in metabolism or energy expenditures. So to combat this rebound phenomena, people have started looking into the eating pattern and changing the pattern of eating. Now, this is how the modern eating pattern looks like. So people tend to eat from the time they wake up till the time they go into bed, and they usually don't eat when they are asleep. So this is one of the reasons why the pandemic, obesity, diabetes, metabolic syndrome, and NAFLD is taking place. And people have tried to modify this by a technique called intermittent fasting, where they use alternative fasting method, or they've used modified alternative fasting method, where they allow about 0 kilocalories during the fasting days and unrestricted calories during the alternate days. There's another technique of using a daily time restricting eating, where the people allow about eating from about 8 a.m. in the morning to about 2 p.m. in the afternoon, and rest of the time they're usually fasting. And what the fasting brings about is, during the first 4 days, it decreases weight, increases resting energy expenditure. They've got beneficial effects in glucose as well as in insulin levels and ketone bodies. In this trial, they showed that the alternate day fasting helped to decrease the body weight from about 4.5% around the baseline, and also decrease truncal fat mass, body mass, and also had beneficial effect on the lipid profile, giving an indication that they may also have some cardiometabolic benefit. There were only one randomized control trial when they had about 30 subjects in the modified intermittent fasting group with 10 controls, and they showed that it was effective in reducing weight, improving ALT levels, as well as improving or reducing the elastography or liver stiffness levels. But again, it's very premature to comment anything based on the small number of subjects in a single trial. Now, coming to lifestyle modification with exercise, Now, sedentary lifestyle, physical activity, and exercise are totally different things. Now, sedentary lifestyle means if somebody spends in a sofa, in a seated position, or on a lying down position for a prolonged period of time, that is sedentary lifestyle. So this is totally different and is not reciprocal to physical activity. Some people may be very physically active during daytime, but when they get back from office, they may be lying in a sofa with the soda-containing drink for about 4 or 5 hours. That is still a sedentary lifestyle. So even physically active subjects can have a total sedentary period, which confers a substantial risk. So one of the way to combat this sedentary lifestyle is breaking sedentary period by frequent breaks. For example, somebody spends in watching TV, they should take frequent breaks every hourly, like standing up and just walking around, moving around, so that they can have a break on the sedentary period. Second thing is physical activity, and they're shown to have direct relationship with the level of physical activity in a population and a NAFLD prevalence in that population. A usual recommendation for preventing cardiovascular disease is about 10,000 steps per day, and this still holds true for prevention or the patients with NAFLD as well. But again, it's very difficult to quantify and assess physical activity, and there are very limited data in NAFLD, but the strong data to support in reducing cardiovascular risk. Now, exercise is a form of physical activity which is structured and is voluntary and includes repetitive, purposeful movement. Now, exercise is an integral part of weight loss program and along with dietary measures, and it can reduce both hepatic fat content as well as improve cardiovascular risk as seen with dietary measure. But if you want to regress fibrosis, exercise alone does not help. You have to achieve weight loss in order to have regression of fibrosis. So exercise has got multiple pleiotropic effects, including improving peripheral insulin sensitivity and decreasing lipid fluxes, decreasing de novo lipogenesis, decreasing visceral adipose tissue, and it has got beneficial effect in cardiometabolic health. The therapeutic recommendation for NAFLD is to have about 6 minutes or high intensity exercise about 75 minutes per week, or about moderate intensity exercise for about 150 minutes per week. If you compare about 75 minutes high intensity versus moderate intensity, it's beneficial to do high intensity 75 minutes workout than moderate intensity 150 minutes per week. But again, cardiorespiratory fitness also has got a very important role in defining who can perform high intensity exercise versus moderate intensity. There are in general 2 types of exercise. There are aerobic exercise and resistance exercise. Aerobic basically focuses on intensity and is good for reducing cardiovascular risk. There's a modified form of aerobic exercise, which is also called a HIIT or high intensity intermittent training. Again, here, subjects are made to do bursts of intense physical activity for about 2 minutes. And again, for next 2 minutes or 1 minute, they're allowed to take rest or have light activity. And this alternate form of, exercise keeps on continuing for some time. The resistance exercise focuses basically on volume and is better in achieving weight loss. There's added advantage of afterburner effect. That means that after you do a resistance exercise, you still be losing calorie or burning calories for about 48 to 72 hours after stopping exercise. So both aerobic and resistance exercise are good individually, and they may also be combined. They can be combined with each other. But again, the preference should depend upon the cardiorespiratory fitness of the subject as well as their preferences. So ladies and gentlemen, to summarize, in general, people should be advised to lose about 5% of weight loss once they have fatty liver. For those with NASH with fibrosis, at least about 7 to 10% of weight loss should be done. For cirrhotic patient, weight loss should be very carefully designed because it should not induce sarcopenia, which may be very detrimental. In terms of dietary options, for patients with NAFLD and NASH, Mediterranean diet, which is rich in monounsaturated fatty acid, is advised. People should be encouraged to take a regular meal, avoid snacking, which is off time, reduce or moderate alcohol intake, and of course, reduce sugar-containing drinks like fructose and glucose-containing drinks. Cirrhotic patients, these patients are very vulnerable to sarcopenia. They should focus on protein intake of about 1.2 to 1.5 grams per kg per day. Small frequent meals, especially midnight snack, does also help in reducing sarcopenia. They should be encouraged to abstain from alcohol and again reduce to take fructose or glucose-containing drinks. All the spectrum of NAFLD patients should be encouraged to take daily physical activity time targeting about 10,000 steps per day, decrease total sedentary time and have a break up of a sedentary time, total sedentary time. Aerobic or resistance exercise, both are good. About moderate intensity, 150 minutes of exercise is good enough. If they can do it for 75 minutes of intense, that's even better. One of the barriers is, how to implement in our clinics. So that is one of the very important question. And in order to do that, we have to understand the patient's perception about NAFLD. There are, again, lots of misconception, like they probably don't know, like eating too much or their obesity is contributing to NAFLD and cardiometabolic health. So we have to clear this misconception and clarify the benefits and importance of lifestyle modification, not only liver-related health, but rather overall cardiometabolic health in terms of decreasing cardiovascular death, stroke, and all, and malignancy and all. Clinicians should help them to make smart targets, smart meals. It should be specific, it should be specific in terms of how much to lose weight, how much to restrict the calories, or how intense the activity should be. It should be achievable, it should not be impractical, it should be relevant, and should be timely. It is, again, very important to support them to choose the dietary plans and exercise, and help them monitor their progress and review their targets again by means of more frequent charting of their weight, diet charting, and pedometers to see the step counts. And it's also very important to support them and also to keep them motivated to maintain their healthy lifestyle modification. Thank you very much.
Thank you, Professor Sharesta, for an excellent talk. Indeed, a very important topic. So with this week, we come to the end of this session. May I request all the speakers of this session, could you please turn your web cameras on so that we can have a question and answer session and discussion. Right. Thank you. I think we have all of them right now. So any questions? I'll start with one question. This has been posted to me. So this is from Dr. Saleh. Sir, can we predict possibility of developing portal vein thrombosis in a patient with decompensated cirrhosis, especially if the patient is a candidate for liver transplant? Dr. Saleh?
Thank you, Kamran. This has been a nice question, and the suspicious level is high in patients who are at more risk. Like if you do, there are a few things. One, this is related to the portal flow, and second is this worsening of the CTP score. So anytime the patients would come to you with worsening ascites or a CTP score or high bilirubin, then one may suspect the portal vein thrombosis, or if they have got now developing hepatic encephalopathy. So any worsening in the physical condition or clinical conditions or the scoring system may prompt you to look for the portal vein thrombosis. More so when their portal hypertension increases, or they have got recurrent infections, or they undergo some procedures, one may suspect that these are those patients who are at risk for portal vein thrombosis, and we should be vigilant in these scenarios.
Right, and you rightly said in your talk that if he is a candidate for liver transplant, then we would go ahead and start anticoagulation in this patient if there is definite evidence.
I have a question.
Yeah, sure. Because
from Professor Dong-Joon. Are you there,
yeah.
Professor? Can you listen?
Yes, I hear.
Yeah. The recent guidelines, the West has discarded this 6 months abstinence rule for liver transplant in alcoholic related cirrhosis. The type of transplant which we're doing in this part of the world is different. Do we follow the same guidelines, or will we stay with the old dictum of stopping rule of 6 months?
At large in Korea, the 6 months rule is largely abandoned, and at nowadays the liver transplant due to alcoholic liver disease is the leading etiology of liver transplantation in Korea.
Okay. I want to ask one more question from Dr. Sudhamshu. What is the current status of hepatitis E vaccine? Although it's not FDA approved, but it is there, and people are using it.
There are two types of vaccine currently in practice. One is from China. They are using it predominantly in Chinese population, and they have recently applied for registration in Nepal also. And another one is the commonly used one is they have 2 doses of vaccine and 1 ml in 1 month interval time. And what I have seen is that they have good potential and they can be used in clinical practice.
Okay. What will you advise for a breastfeeding in a lady who has been infected with hepatitis E?
There are no such guidelines, but yet since the breast milk can have the hepatitis E virus, but the transmission has not been reported so far. And in case of acute hepatitis E in pregnancy, usually in 3rd trimester, they have very fulminant course in around 20% of the cases. Those who are free from the disease or those who don't have this liver complication, they usually clear the virus easily. So I think in my clinical practice, I don't bear female from breastfeeding.
I can put a question to Sudhamshu. Can you hear me?
Yes, yes.
Yeah. My question is that the use of ribavirin has been successful in genotype 3, where people are immunocompromised.
Yes.
So this can be translated in genotype 1 and 2, and can steroids can be used for these extrahepatic manifestations, because they seem to be immunologically modulated. If I believe that there's a theory about the activation of immunological mechanism in these all extrahepatic manifestations.
Yeah, very right question raised. But the problem is that we don't have this trials on use of ribavirin in genotype 1 or 2. In my clinical experience, I have used this in acute liver failure in pregnant women. The pregnancy terminated, but the patient was saved. So there is only some anecdotal reports only, but maybe yes, in case of extrahepatic manifestation, especially in kidney disease, it's tried, but it's mostly genotype 3. And maybe in our part of the world, acute pancreatitis is common. So maybe we can try this therapy in acute pancreatitis cases, but I haven't tried yet.
Next to Salih. Salih, you have used, I think, warfarin and these low molecular weight, but have you experienced or seen any comparison where warfarin versus low molecular weight heparin or newer agents of anticoagulants being compared with each other, how they are successful, what is the outcome in each of these, and which is the most safest and the effective of these 3 modalities of anticoagulants?
Thank you, sir. We have studies comparing the directly acting antiviral with warfarin, and they seem a little superior even than that. Now, heparin versus oral drugs, they are basically, it's the ease of administration, and second is that the availability and all that. Warfarin seems to be a bit more tricky because you need to have a maintained level of INR, and at times it's very difficult because it may not be available in the far-flung areas. So either you go for, these days now, direct antiviral drugs, directly acting anticoagulants, or low molecular weight heparin. But even currently, you may have noticed that the availability of the low molecular weight heparin is at times very tricky. So that's how we are more now clinically using these directly acting oral anticoagulants. They are equally effective also.
And what's the expected outcome? Portal vein thrombosis get dissolved in how many % of cases?
Look, the dissolution is basically done by the body. It's not these drugs, as you know better than me. And the other thing is that up to 70% of the percent of the times, there will be at least they will achieve partial recanalization, and more than half would achieve full complete resolution. And those patients who would achieve near complete or partial resolution are also at risk of further worsening. As you know, that they would occur more in the decompensated cirrhotic and more so when the portal pressures are high. So this means that you need to keep these vessels patent till you would transplant these patients.
Can I move on? Another question?
Yeah.
Okay, the question is to Dr. Kim. Sir, what is the experience of using pentoxifylline? The steroids sometimes get exhausted, they have side effects. So do these guidelines recommend the use of pentoxifylline as an anti-inflammatory, and it's an oral agent? What has been the experience of use of that agent?
10 years ago, okay. Can you hear me?
I can hear you, yes.
We can hear you, sir.
Yes. Before the STOPPA trial and 10 years ago, some institutions used pentoxifylline instead of steroid. And pentoxifylline is a very safe drug in the situation of severe alcoholic hepatitis. But the evidence does not prove survival benefit in using pentoxifylline. So most of guidelines, all of guidelines recommend steroid as a first-line therapy, not recommend pentoxifylline.
Okay, one question for Dr. Mohammed Alboraie, that we do see that we face a difficulty in managing variceal bleed in pregnancy when standard therapy fails, especially with the handicap that we can't use vasopressin and octreotide in these patients. Then what we can do for these patients?
We can use octreotide, but we cannot use terlipressin. Terlipressin is pregnancy category D. Also, we have the rescue therapies of TIPS. It has the risk of radiation to the patients, but if it's done with an experienced hand and a fast procedure, it can save life. Surgery is extremely difficult and extremely risky in those patients, but we may have surgery as the last resort on some patients. So stepwise approach will be controlling the variceal bleed with an endoscopy and pharmacotherapy, but don't use terlipressin because it's category D. If this failed, we can try TIPS, and we have few case reports, 3 to 5 case reports that has been published about using TIPS in pregnant females, and these were all successful. So don't be afraid for the risk of the radiology if you are doing with an experienced hand and the fast procedure, the TIPS itself.
All right, thank you very much. So I have a question for Professor Ladden. First of all, thank you very much, Professor, for joining us on this platform. So the question is, the impact of climate change on various GI and liver diseases is a huge challenge. And this is an area which is quite neglected one as well. So how do you see the way forward, how we can actually educate our healthcare providers and bring their attention towards this area, and the way forward to implement the strategies where we can actually do something about this problem and minimize. We can't minimize at the moment, it's a huge problem, but at least we can move forward to control this situation.
Yes, thank you, and thank you for the opportunity to speak to your group today. I think to this point, there has been a huge amount of very high quality science done around climate change, but for some reason it has not translated over to the medical community, and physicians, and medical students, and postgraduate trainees really do not know much about this topic. But increasingly, climate change is being seen as a major health issue. And I would refer you to the Lancet 2020 report, which was published this week, a very comprehensive review of the health impacts. So in terms of moving forward, I think the first thing that we have to do is educate our physician populations on the issue. And that it will involve getting this into the undergraduate curriculum, postgraduate training, and as you have done, put it on for peer meetings. The major signal so far with regard to health or major attention has been around respiratory disease, but I am quite sure that there's a major signal there for liver disease if we start to look at it. And I think we have to start focusing in on this issue and take it on, much as we did with smoking in the 60s, and regard this climate change issue as a public health problem.
Right. So I have a quick question. As a moderator, maybe I can take the privilege to ask this question. My question is from Professor Sharesta. Very elaborative and very practical points that you have elaborated. How do I tell my patient what exercise to do? I mean, if my patient comes to me and says, Doctor, I don't have much time, just tell me one exercise which I can do to reduce my weight or to help me reduce my fatty liver. So what would you suggest? What tip would you give for such patients?
Thank you for the nice question. This is indeed a very important practical problem that we face in everyday clinical practice. Now, there are certain factors that helps us to decide what kind of exercise do we suggest or prescribe these patients based on what kind of liver disease they have. The first is, after initial assessment, if they have significant fibrosis, we need weight loss. If they don't have significant fibrosis, then we can probably stick them to just have a fatty liver with raised transaminase level, or maybe NASH, but doesn't have a significant fibrosis, that probably weight loss may not be very important. So for those people who require weight loss, they need a combination of dietary measures plus exercise. The exercise, as you say, some people are very busy. Maybe they just have about 30 minutes of time. And if you really want to prescribe these people, one of the way that I usually suggest is doing a HIIT. HIIT is high intensity training. Now, what we do is, for example, somebody's on a treadmill. Now, if somebody runs at about 10 kilometers per hour for about 30 minutes, he will be burning somewhere around 200 to 300 calories of energy. But if you do this, utilize the same time, 30 minutes, but you do it a different way. So you make him run about 12 to 14 kilometers per hour for about 2 minutes. And then you just make them walk for about a minute. So you're just splitting a cycle of 3 minutes where you making the patient run for about 2 minutes, and then he'll take a break for with walking at about 6 kilometers per hour for about 1 minute. So, and it keeps on repeating. So you'll be losing more calories by this method. So HIIT is much more effective in terms of losing more calories in the same 30 minutes duration. So that is one way. Number two is, if somebody can do resistance exercise along with aerobic exercise, the combination works even better. So as a warm-up, they just do aerobic exercise just on a cross trainer, or maybe working on a training, and then they do some form of weightlifting or resistance exercise. But again, you have to decide what are you trying to achieve. For example, if somebody is just has a fatty liver and NASH but doesn't have a significant fibrosis, it may not be necessary for them to lose weight. So walking for about 10,000 steps per day, and maybe doing about moderate intensity exercise, or maybe just brisk walking, or even running for about say about 20 minutes or 30 minutes a day works quite well. But if you really want to achieve regression of fibrosis, you have to be a bit intense.
Yeah, same question, but in a different way to Professor Sharesta. That do you allow your patients to go for a keto diet weight loss plan?
Well, I don't recommend, but then people are doing keto diets with good results. But if some patients come to me and they just ask me if I can go for a keto diet. But if these people do have cardiovascular risk, if they have diabetes mellitus, if they are pregnant women, I say definitely no for these patients. But for otherwise healthy people, maybe they can take a risk. But then what I advise them is intermittent fast is better than keto diet. So that's even much better in terms of the safety profile. So if somebody comes for opinion of a keto diet, I would rather switch them to intermittent fasting rather than sticking to keto diet.
Okay, so one quick question from Dr. Salih. Does the dose adjustment for anticoagulation is needed for these patients like with cirrhosis, maybe for portal vein thrombosis?
Thank you, Amna. The quick answer will be no. Specifically, the dose adjustment is needed, like somebody, if you are using low molecular weight these fractionated heparins, and if they have got deranged creatinine, then you need to adjust, otherwise you don't. The other thing would be if you are giving them warfarin, and if they are on some, you want to use some antibiotics or other medications, and you hope that one should be careful that they may increase or decrease the INR. So the dose adjustment is basically dictated whether the patient has got some more kidney injury or not, or you are using some medication which may increase or decrease the levels. Otherwise, you don't need to.
Thank you. Another quick question for Professor Mohammed Alboraie. So, Dr. Mohammed, how to monitor the pregnant ladies for the adequate dose of beta blockers? For non-pregnant patients, usually we try to keep near to the 60, 65, something like that. But that actually this range may actually induce fetal bradycardia. So, what should be a safer range of heart rate we can actually maintain for pregnant patients?
Thanks, Amna. Usually we do this in a multidisciplinary team, as I mentioned in the lecture. So our patient has to be seen regularly every month, and we do the clinical examination, and we assess the heart rate for the mother. And in the last trimester, we also assess the heart rate for the patient, the fetus. I don't have an answer for the fetus, but for the mother, we keep it the basal heart rate in the beginning of the pregnancy. But for the fetus, I usually consult my OB/GYN or obstetrician to follow it.
Thank you.
Right, I think we can go on and on with this. These are such important and very interesting topics, and a lot of questions have been generated from these talks. But unfortunately, it's time to end now. So I will request our respective chairs, to quickly have a final word. I think we can invite our chairs who are online. Dr. Zishan Ali, are you there? Dr. Zishan, maybe a couple of words. Dr. Zishan? I think Dr. Zishan, we lost. Right. Dr. Abdul Qadir, if he's there, Professor Abdul Qadir. Okay, so we can start from Professor Ashfaq.
Okay. Thank you, Zagam and Amna, for providing this wonderful 3 days, which has been very dynamic, full of knowledge, and very interactive, which has been seen in the last session as well. People have been involved, and I'm thankful to all the speakers for being so up to the time, and the content was excellent. Presentation was crisp and clear, and the topics were very well covered. To start with, Sudhamshu has covered hepatitis E with extrahepatic manifestations, opened up new avenues to think about, and I think all of us have become more learned with this full of knowledge presentation. And I believe that genotypes in hepatitis E has been shown here. We have been seeing new genotypes. Genotype 7 has been shown to be coming up in camel and in meat coming from camel milk. So these genotypes are increasing, and we should be very up to date in these areas. The second was environment, and the environment become very hot in this part of the world. As we get hotter, we are getting more problems. As I think Zagam and we have been discussing in the past, that aflatoxins have been cancerogenics, storage for grains and storage for rice have been in problems. So I think climate is going to be a very, very important topic to cover and to see and address these areas, and we are thankful for the presentation which has covered and excited new thoughts about the area. The alcohol-related problems are very common here. We need to tackle these, and again, these presentations are not to be, I think it cannot be, I cannot say more about these presentations. The pregnancy is very common. The pregnant ladies taking care by hepatologists is a common problem. It's a multidisciplinary area. I think we have to make and create teams for that, and that's very well mentioned here. Dr. Saleh has talked about the difficult area, which needs a teamwork, which need awareness among all team members to be on same page. Anticoagulating these patients is a hectic job, and a hectic vigilant team is required, and which has been very easily mentioned by Saleh, but practically it's a difficult area to carry on. And carry on with the ongoing bleeding and ongoing varices is a difficult job to do, but I think we have seen good outcomes, good result of these anticoagulants, and people have benefited, and this should be the state of affairs, that we should be able to anticoagulate portal vein thrombosis, which has resulted in better outcomes. NASH is always a difficult topic. NASH, to start with, 5%, 10% weight reduction. I think we have heard about exercise, we heard about the change in lifestyle, and we have been listening from surgeons about surgeries in these patients. So I think the primary thing has been mentioned very nicely. Change of lifestyle, this is the primary area to hit. And so overall, the presentation was marvelous, and I'm thankful to the organizer again for inviting us here, involving us here. Thank you, Zagam and Amna.
Dr. Dasir, if you have anything to say, concluding remarks.
Yes, I became nostalgic when Professor Dessmond Ladden was saying this climate change thing. I was on ground serving for 3 months, and about 200 million people were all affected by this flood, and we had lots of malaria, and later we fought with dengue fever, and we had lots of gastroenteritis and liver related problems as well. So the other topics which we included in Potpourri was fantastic, and everybody did justice to their topics, and we're very happy to listen to these all presenters of ours. Thank you.
Dr. Abdullah bin Khalid.
First of all, congratulations to the organizers, Dr. Zagam, Dr. Amna, and all the speakers who took their time out and to educate masses. And I'm sure people around the world are keenly listening to these updated talks by all the speakers. Especially some of the talks over here were excellent and were very innovative to the sense that people do not know about it, especially the climate change talk, the hepatitis E, and the others as well. So I would like to thank all these speakers, and especially the climate change aspect. We all need to, I think, after listening to this talk, we all need to sit together and devise a plan and a strategy for our future generations. Thank you very much.
Right, so to end this session, it remains for me to thank all the speakers, all the chairs who have taken time out for this excellent session, and I think to make it a success. So with this, I sign off, and I hand over the mic to Dr. Amna for the closing ceremony.
Thank you very much, all speakers, chairs, and the participants. And honestly, we are getting instant feedbacks on our WhatsApp group, and the people are liking this session like anything. And probably like within few minutes, we had like so many responses from the participant that probably this is far more as compared to other symposiums. So thanks again. Thank you very much. Thank you.